Hi everyone. Today we are presenting our studies on using machine learning to predict diabetes. My team member are myself, Shukri, Hina, and Freshta. We worked with over 100,000 patients. Hello everyone. Today we are presenting our study on using machine learning to predict diabetes. Our team member is myself, Shukri, Hina, and Freshta. We worked on 100,000 patient Kaggle data set to compare three classification model and investigate how data pre-processing affect their performance. We will walk you through the methods, results of what they mean for healthcare applications. This is the presentation outline of what we'll be covering today. We will start with why early diabetes detection matters, and then describe our data set and how we prepared it. From there, we will explain our three machine learning models and how we evaluated them. The heart of the presentation is our results section, where we compare model performance using accuracy, recall, and AUC. And we will close with a discussion of what we found and where the work would go on next. Just to give you a quick problem background, diabetes affects over 537 million adults worldwide, and nearly half of all cases go undiagnosed at any given time. Diabetes progress silently. Patients often do not realize they have it until serious complications like heart failure or vision loss appear. In our data set, only 8.5% of patients were diabetic, which reflect this real world challenge. Machine learning offers a promising path forward. By analyzing routine clinical data, we can flag at risk patients earlier and support better treatment decisions for providers. Our dataset overview comes from Kaggle, and it contains approximately 100,000 patient record across 9 features. The clinical variable include blood glucose level, A1C, BMI, hypertension, and heart disease. Demographic features include age, gender, and smoking history. The target variable is binary 0 from 0 for no diabetes, 1 for diabetes. We use Weka for model building and normalization, Excel for initial data cleaning. Note that our target column is marked amber. It's what all our models are trying to predict. This is our descriptive statistics. Looking at the data descriptively, our patient population had a mean average of 42 years and a BMI of 27.3, placing the average patient in the overweight range. Blood glucose average is 138, which is elevated. Only 8.5% of patients are diabetic. You can see this clearly in the pie chart. This class imbalance is important. It means a model that always predict no diabetes would still score over 91% accuracy. That's why we also track recall and AUC, which is more sensitive to performance on the minority class. The age distribution histogram shows our patient stews towards middle age, with the largest group in the 41 to 50 bucket. Data pre-processing. Before running any models, we cleaned the data into two key steps. First, we handled missing values, replaced gaps in numerical column with the column mean, and the gaps in a categorical column with the most frequent value. Second, we labeled, encoded the categorical values. Gender was mapped to 0 for male and 1 for female, and smoking history categorical were assigned numerical label so Weka would process them. We then applied normalization within Weka during training. We preserved two versions of data set, raw and clean, so we could directly compare models' performance before and after pre-processing.
So we evaluated 3 classification models to compare their performance. We started with logistic regression, which served as our baseline model. It's a linear model that is fast, easy to interpret, and useful for understanding which variables may influence predictions. Next, we used a decision tree, specifically Weka's J48 implementation. This model can capture more complex nonlinear relationships in the data and also produces decision rules that are easier to interpret. Finally, we used random forest, which is an ensemble method that combines multiple decision trees. This approach helps reduce overfitting and usually performs better on larger or more complex data sets. Since each model has its own strengths and limitations, comparing them allowed us to better understand which approach worked best for predicting diabetes using healthcare data. For evaluation, we used tenfold cross-validation on both the raw and clean datasets. As shown in the diagram, the dataset was divided into 10 equal parts or folds. During each round, one fold was used as the test set, while the other 9 folds were used for data or for training. This process was repeated 10 times so that every fold was used for testing once, and then the results were averaged together. Using this approach helps produce more reliable and unbiased results, especially with a large data set like ours. To evaluate model performance, we focused on 3 metrics: accuracy, recall, and AUC. Accuracy measures the overall correctness of the model. Recall measures how well the model identifies patients with diabetes, which is especially important in healthcare settings, and AUC evaluates how well the model distinguishes between diabetic and non-diabetic cases overall. Here are the full results across all 6 model and dataset combinations, and a few things that stand out right away. First, all of the models achieved accuracy values above 95%, which shows strong overall performance across the board. The decision tree model on the clean dataset achieved the highest accuracy at 97.1%, along with the highest recall value of 0.998. This means the model was able to correctly identify almost all diabetic cases. The random forest model on the clean dataset achieved the highest AUC value at 0.966, which suggests that it had the strongest overall ability to distinguish between diabetic and non-diabetic patients. Overall, pre-processing did lead to some improvements in performance, although the differences between the raw and clean datasets were fairly small, which suggests that the original dataset was already relatively well structured. For easier comparison, the best performing values in each column are highlighted in the table. When focusing specifically on accuracy, we can see that both decision tree and random forest models performed slightly above 97% on the clean dataset, while logistic regression performed around 95.5%. The darker bars represent the clean dataset, and across all 3 models, pre-processing resulted in small but consistent improvements in accuracy. Although the differences between raw and clean datasets were not very large, The results suggest that the original dataset was already fairly well structured. Even so, pre-processing still helped improve consistency and overall reliability in the models. So in a healthcare setting, recall is one of the most important evaluation metrics because it measures how well the model identifies patients who actually have diabetes. A false negative, meaning a diabetic patient being missed by the model, could have serious clinical consequences. Among the models, the decision tree achieved the highest recall value at 0.998 on the clean data set, which is extremely high. Random forest followed with a recall of 0.983, while logistic regression achieved 0.963. Across all three models, the clean dataset consistently performed slightly better than the raw dataset. Overall, the decision tree's near-perfect recall makes it especially promising as a potential screening tool for identifying patients at risk for diabetes. AUC, or area under the ROC curve, measures how well each model can distinguish between diabetic and non-diabetic patients across different decision thresholds. In this comparison, the random forest model performed the best, achieving the highest AUC value at 0.966 on the clean data set. Decision tree followed with an AUC of 0.952, while logistic regression had the lowest at 0.843. The amber bars represent the clean data set, and we can see that pre-processing led to noticeable improvements in AUC across all three models. The lower AUC value for logistic regression may be due to the fact that it is a linear model, which can make it harder to capture more complex relationships that exist in real-world data. This slide combines all three evaluation metrics into one chart using the clean data set. Recall and AUC were scaled by 100 so that they can be compared more easily alongside the accuracy percentages. The overall pattern is pretty clear. The decision tree model performed the best in terms of accuracy and recall, while random forest achieved the highest AUC value. Logistic regression still performed consistently, but overall it scored lower than the other two models across all three metrics. The main takeaway from these results is that the best model depends on clinical priority. So if the focus is on identifying as many diabetic patients as possible, the decision tree model stands out because of its very high recall. On the other hand, if your overall classification performance is the priority, then random forest would likely be the stronger choice.
Reflecting on what we found, the most notable result is that processing had a modest but consistent positive impact. The dataset was already well structured, so improvements were incremental rather than dramatic. The class imbalance with only 8.5% of patients having diabetes is the biggest challenge. It's why recall and AUC matter more than accuracy here. The high recall of decision tree is particularly valuable clinically, since missing a diabetic diagnosis is far more costly than a false alarm. From a practical standpoint, both decision tree and random forest are viable tools for supporting early diabetes screening in clinical setting. Their main limitations are the class imbalance issue, the absence of advanced feature engineering, and the fact that we only tested 3 model families. To summarize, all 3 models performed strongly, exceeding 95% accuracy. Decision tree was the best performer on accuracy and recall, while random forest led on IUC. Data pre-processing produced consistent, if modest, improvements across the board. For future work, we would recommend 3 directions: applying resampling techniques like SMOTH to address class imbalance more directly, exploring gradient boosting methods or neural networks for potentially higher AUC, and conducting feature selection or engineering to identify the most predictive clinical variables. This concludes our presentation. Thank you so much for your time, and we are happy to answer any questions you might have.